Today, I will help you how to recognize psoriasis patient. On low power, you'll find what's called psoriasiform epidermal hyperplasia. It means we have a cansotic epidermis with elongation of retirage. Look how long is the retirage with preserved retipapillae configuration. This is the retirage and in between the dermal papillae. So you'll find we have a preserved configuration and almost all the retirage have the same length. By the way, the biopsy here is shave. We don't like shave really in inflammatory dermatosis. We prefer punch biopsy, but it's a good one. We have all the epidermis and the polydermis in the slide. What's characteristic for the psoriasiform epidermal hyperplasia is this portion. This portion above the epidermal papillae called suprapapillary portion or suprapapillary plate. And the plate here is shows thinning. There is only maybe 2 or 3 layers of keratinocytes here. So we have a canthodic epidermis with elongation of retirage, preserved reticular configuration, and thinning of the suprapapillary portion. And as you see here, we have a confluent parakeratosis. Okay. Also, you can see the blood vessels. The blood vessel is very important in psoriasis. You will see all this white space lined with endothelium are blood vessels. So we have dilated tortuous blood vessel in the papillary portion. The dilated tortuous blood vessel with the thin suprapapillary portion responsible for what called Elisabeth sign. If you scratch the skin, you will remove the scale layer by layer until you have this pinpoint petechiae due to the dilated tortuous blood capillary. If we go for another patient, as this patient, again you will find we have a cansotic epidermis, we have elongation of retipapillary configuration. It is not well formed as the last one, but you can appreciate with thinning of suprapapillary portion. I think the thinning here is very obvious, maybe only 2 or 3 layers of keratinocyte. You can see we have no granular cell layer at all at some time. In psoriasis, you can have no granular cell layer or diminished granular cell layer. What's nice also, again, you have dilated tortuous blood capillary. Show how nice are the blood capillary, dilated tortuous and filled with RBCs. The good about this slide is the corneum. You can see we have parakeratotic corneum, but not only parakeratosis. There is something in between the parakeratotic cell. The parakeratotic cells are these with small nuclei as lines. They are retained in striatum corneum. But in between you can find this dirty blue ant-like structure. They are newts, they are neutrophils, as here, dirty blue ant structures. You'll find a layer of parakeratosis, then you will find neutrophils entrapped in the striatum corneum, and again parakeratosis. This layering is very important in diagnosis of psoriasis. It's called also sandwich sign. You will find a layer of parakeratosis, layer of newts, and then a layer of parakeratosis. Again, we have collection of newts here. Again, parakeratosis. Then we have large collection of newts, but this one is not on the striatum corneum. It's go for the epidermis itself. So we have subcorneal collection of newts. Again, parakeratosis, parakeratosis, parakeratosis. So we have all features of psoriasis. We have psoriasiform epidermal hyperplasia, thinning of suprapapillary portion. We have dilated tortuous blood capillary. We have newts in striatum corneum. The newts forming subcorneal pustule and making layering was described as sandwich sign. My question for you, by the way, you'll find the newts in striatum corneum in many dermatoses. They have an abbreviation called P-TEX. P for psoriasis, T for tinea, I for impetigo, C for candida, S for seborrheic dermatitis, and the last one is for syphilis. Okay. By the way, here in our slide, you can find spongiosis. There is a false belief that in psoriasis you will not find spongiosis. You can find spongiosis. Even there are 4 types of psoriasis which are spongiotic. They are erythrodermic, guttate, inversed, and acral type. They have too much spongiosis. And you can find spongiosis, mild spongiosis in most cases of psoriasis. That's what makes it is difficult sometimes to differentiate from spongiotic dermatitis. We can go for this patient. Again, we have acanthotic epidermis, we have elongation of retirage, we have thinning of suprapapillary portion, so we have what's described as psoriasis form epidermal hyperplasia. You can find also the prevascular infiltrate. It is superficial prevascular infiltrate. I will go higher power to show the nature of infiltrate. It is mixed infiltrate formed of lymphocyte and histocytes with fibroblast. Okay, go for the epidermis, which contains the main pathology. You will find nice parakeratosis with newts. I will go higher power to show you. Look, we have acanthotic epidermis, thinning of suprapapillary portion, no granular cell layer. Then you will find a thin layer of parakeratosis. Then you will find newts. This dirty blue ant-like structure are neutrophils. Neutrophils, when go up in stratum corneum, they become crushed or smudged. Okay, then a layer of parakeratosis, so we have a nice sandwich here. Again, we have newts on top of the stratum corneum, then we have parakeratosis, so it's good for psoriasis. Again, newts in the corneum, parakeratosis, newts in the corneum, then parakeratosis. This nice layering go with psoriasis. Again, the dilated tortuous blood capillary with mixed superficial prevascular inflammatory infiltrate all point to psoriasis. After psoriasis, clinically you can see pustules. There are pustules in the patient, and this can be reflected on the histopathology also. You can find this nice subcorneal pustule. Here is our stratum corneum, and you can find this large space which is filled with these nice neutrophils, all these ant-like structure or funny nuclei, multilobule, the Mickey Mouse, they are all describing neutrophils. It can be large subcorneal pustule, or even it can be small subcorneal pustule like this one. Collection of newts below the stratum corneum. Okay. Thank you.